everyone. Welcome to our podcast focusing on infection prevention and control topics. I'm Dr. Supriya Manapali, Medical Director for Infection Prevention and Control at Northeast Georgia Health System. Joining me today is Sandy Bozarth, Director for Infection Prevention and Control, Northeast Georgia Health System. Thank you, Sandy, for joining me today. The topic today is measles. We've been monitoring very closely, and the most recent CDC data shows there have been more than 700 cases of measles confirmed this year, and we are in April. These cases have been across 25 different states, and there have been at least 7 outbreaks identified. Most of the cases have been involved or associated with outbreaks. So with this now, especially with concern for measles, what are we doing from infection prevention control to ensure that when a patient presents to any of our health system, EDs or urgent cares or primary care offices, what are we doing to ensure patients are properly isolated?
Well, the best way to prevent the spread of measles is, of course, prompt recognition, reporting and investigation. As you said, it's highly contagious, but the spread of the disease can be limited if we have that early identification. So we teach our staff to identify, isolate, and inform, and that means look for the symptoms of measles. Sometimes they're not textbook presentations, and then put them in the proper isolation, and then inform infection prevention and public health when there is a suspected or case that shows up.
So anytime there is a suspected case of measles in any of the locations in our health system, it's very important to notify both public health and infection prevention and control.
That is correct. It is correct.
And what type of isolation precautions are recommended when we have a suspected case of measles?
We place those patients in airborne isolation, and that, again, I repeat myself, that's for both suspected and confirmed cases, and that's a single negative pressure room, and staff will wear N95 masks when they enter the room.
Thank you, Sandy. And you mentioned about the clinical presentation. Again, measles, the initial symptoms can be very nonspecific. Fever, the 3 C's we hear, the cough, the coryza, conjunctivitis. And then it's very important to look in the buccal mucosa inside the mouth to see if there are any of those bluish-white Koplik spots. And then the rash starts, and the rash starts head and then spreads down to the trunk. It's very important to ask about the vaccine status, because one of the recent cases, it was that history of the vaccine status that increased the suspicion that ensured prompt testing. So once we have a patient who is presenting with suspected case of measles, then what are the next steps? Do they have to be always admitted, or can they go home?
Not always admitted, but it's just important to say that if they are in our healthcare facility, we place them in the negative pressure room, and that's for 4 days. Past the onset of the rash, and the day 1 of the rash is considered day 0, so 4 days. Now, if a patient's immunocompromised, they will stay in the airborne precautions for their entire stay, because they can shed that virus, as you know, for a prolonged time.
I think that's very, very important. So from the rash onset, the day of the rash onset is day 0, and then 4 days minimum for those who are not immune compromised. They have to continue the isolation precautions. And when we recommend airborne isolation, these patients have to be in a negative pressure room. What about locations that don't have negative pressure rooms?
If a patient needs to stay in medical care, they will transfer to an area that does. So they'll place a medical grade mask on the patient for transfer, let the accepting facility know we have a suspected case coming, so they can be prepared, and then that patient will go to a negative pressure room at that facility.
Thank you, Sandy, for sharing that. It's very important that if we're seeing a patient, whether presenting to primary care providers, office, urgent care, if there is concern for measles, that these patients are roomed immediately. They're not sitting waiting in the waiting area with other patients, and they're immediately roomed. And even if there's no negative pressure room, at least a regular room with the door closed until we can, if they have to be transferred to a facility with a negative pressure room, then that will happen. And we also take additional precautions not to room another patient
in
for
that
some time.
room. Yes,
Yeah,
that was
immediately.
that's an interesting fact about measles as
Yeah.
well, and because it can stay suspended in the air for up to 2 hours.
Yeah.
So even going into a room where a measles patient
Yeah.
was previously, you could be
Yes.
exposed.
So that's very important that we don't room some other patient who may be susceptible immediately after that patient. And also, if we look at how contagious measles is, if a patient with measles can spread the infection to at least 12 to 18 other susceptible individuals. So very, very contagious. Compared to COVID, if you have to compare to another viral illness, a COVID infection can spread to maybe one or two others, susceptible individuals. So extremely contagious. And I think there are some studies I was seeing 9 out of 10 susceptible individuals got infected when exposed. So highly contagious. And the most effective method to prevent measles is vaccine. So it's very important for us to stay up to date with vaccination. And MMR is the vaccination that's used, and it's recommended 2 doses. 12 to 15 months is the first dose that's given, and then between 4 to 6 years, the children receive the second dose. And a lot of questions we have received is about those who are born before 1957, because historically that's considered as presumptive immunity to measles. There used to be millions of measles cases per year pre-vaccine era. And there were some studies that showed that almost 95 to 98% of those born during that time, that before the 1957, actually had evidence of immunity. But there may be some that are not. So it's very important, especially in healthcare workers, those who are traveling internationally during outbreak, ongoing transmission, to check for immunity. And if they're not immune in the adults, at least receive 1 dose of the vaccine. But in healthcare workers or other high-risk individuals, they need to receive both the doses. So very, very important, because there is no specific treatment for measles. Vaccine is our only tool to prevent these infections. From a testing standpoint, once we notify the public health, of course, we'll receive guidance from them. And the testing will include both testing a throat or nasopharyngeal swab and blood. The PCR is the most sensitive test. Also from the blood, we check serologies. And urine also can be tested, because then the urine that increases the yield the more samples we send. So, but once we notify public health, we'll be working very closely under their guidance. So if someone has unprotected exposure to a patient with measles, then what are the next steps?
If an exposure occurs in our healthcare setting, we do contact tracing, and it's important to know that that includes not only our staff, but other patients and even visitors. And then that list is turned over to our occupational health and the Department of Health. And then the public health department then begins doing surveillance to look into other key possibilities of exposure and tracing, because as we mentioned earlier, identifying these cases is really the key to stopping the spread.
That is so important. Early identification, isolation, and informing our public health and infection control. Those are the 3 most important steps to prevent the spread. Anything else, Sandy, that we have not talked about that we should share with our audience?
Those that have been exposed and they are not immune will be asked to stay home to quarantine for 21 days. I don't believe we mentioned that, and I think that's crucial.
Yes.
I think the big takeaway for a healthcare system is to identify it.
Very important.
Sometimes it doesn't come, show up at our door looking like, oh, this has to be measles. And as you mentioned earlier, also checking that vaccine status is huge too.
I think that's so important, because I think when we're seeing a patient presenting with a rash or a febrile illness without rash, because patients may present before the rash onset, with the cough, the coryza, conjunctivitis, doing a good exam, looking at the buccal mucosa, asking the vaccine status, asking about any travel, any known sick contacts, exposures. All of this will increase the suspicion,
absolutely.
So that we can isolate the patient and do the testing. How are we raising this awareness as we're seeing increasing cases of measles? What can we do, or what have we done and continue to do to improve the awareness?
I think it's educate and educate and educate. We have in our healthcare facility, we have flyers that we have sent to the key entry points, to the emergency room, the urgent cares, just with actual pictures of what this what this presentation could look like, just to keep it at the front of people's mind that this could be measles. Always have that as a thought for diagnosis.
That's so important. And we do use our medical staff newsletters, the infection control newsletter, NGPG newsletter. So we continue to use various avenues. Of course, this podcast that we're doing to improve that awareness about measles. So when we have a patient with suspected measles, they're placed in airborne isolation precautions. What if there's someone that's not been fit tested for N95? Can they take care of that patient?
No, and that's an OSHA mandate. If you are doing a job that requires that you wear an N95 or an equal, you must be fit tested. And the reason is that it's important that mask fits securely around your face for the true protection. Sometimes someone will have a facial hair, so they can be fit tested, and there's an opportunity for a PAPR, which is another type of respirator, although not all facilities have PAPRs available.
I think that's so important, right? Because very important that it's not just using any N95, it has to be a fit tested N95. And if you cannot be fit tested for N95, then the alternative would be a PAPR. Or we have to assign someone else to care for that patient. Of course, we are seeing increasing cases of measles. We're also seeing increasing cases of TB recently. So when there are patients that have to undergo aerosol generating procedures, do we need to change how we have done things routinely in general, not necessarily someone who is an obvious suspect? Of course, the ones who are suspect or confirmed cases will be in the airborne isolation. But when we are doing these high-risk procedures that increase the risk of transmission, do we need to change how we have done these procedures?
Aerosol-generating procedures should be minimized, if at all possible, on these patients. Both of these are airborne isolation. They already are considered airborne disease, but that aerosol-generating procedures increase the amount of virus in the environment and increase the risk greatly. So if at all possible, we try to minimize those type of tests during their contagious period.
That's for those who have a suspected or confirmed cases, right, Sandy? But what if we actually have a patient that is scheduled for a bronchoscopy?
Oh, I see.
And it's not a suspect case. With the increasing cases.
Yes, we recommend still using an N95 mask. That is a good thought. Just because as we've mentioned so many times during this podcast, it is not always, particularly with TB. It's TB, not always a textbook presentation. And so it's safest to use the N95 when you're doing a procedure that puts you at increased risk.
I think that's something which will be a change, or has been a recent change for us in the last year or two because of increasing TB cases, along with eye protection, also using a fit test at N95 for these high-risk procedures, for bronchoscopic procedures. So again, I think it's so important to think of measles in the differential when we are seeing someone with febrile illness with or without rash. Ask about vaccine status and place them in proper isolation precautions pending the workup, and ensure infection prevention and control and public health both are notified. Now, thank you, Sandy, for joining me today for the podcast. Again, last but not the least, most important message, please stay up to date with your vaccinations.